presentation by Saioa Armendáriz, the economist from the IMF, and I'm gonna do it here just for you, because later, I mean, there is gonna be everything video for everyone, and the video will be also in the video of the Congress in any case for the others, and but for us it's enough. I just got the news that there is no translation for us in the room today, so do you follow? Good. So basically, I will talk both in Spanish and English, and which is, I'm fortunate to be Spanish, so that should be fine. So let me first. Well, Professor Du already. Well, he should come soon, I guess, because he was here a few minutes ago. Let's see if he comes. But in any case, let me introduce this panel. This is something quite important in our lives, because in any country we want to have health systems, and we want to have sustainable health systems. So it's not only about the question in this type of matters is not only about having the human right to health, which is fine as a definition. I'm not a lawyer, so I'm sorry about that. But you know better than me about the human right of access to health. But it's not about health, but it's about accessing to health in a health system that actually works functionally and with the goal of sustainability. So it's not only about providing health services or providing health insurance to the population, but also providing the way towards this access of services to everyone. And in some countries, we have some national health systems. In other countries, there is a social health insurance system. So basically, we can organize that in very different ways, and it's fine. But we need to take care of the efficiency incentives, and we need to take care of this human right of accessing to health. So having said this very brief introduction, let's start with the discussion. This is this panel. The title of this panel is Human Rights and Sustainable Access to Health, as I was saying, and I'm very proud to have this very important group of speakers. The order of the presenters is going to be the one that I'm going to give you. Is the one that I will give you now. Now what I'm going to do is I'm going to introduce each of the speakers, and then we will start first with Saioa Armendáriz, because she's not present here in the room. We have just a video. I will show the video here from my computer, and then anyway it's going to be available for everyone in the internet. So Saioa Armendáriz, she's a Spanish economist. She works at the International Monetary Fund in Washington, D.C., and she's sorry that she cannot join today here presentially. She has a very strong experience, because even if she is working now at the IMF, she has a very interesting curriculum, and she has combined different types of jobs. She's working now at an international organization, at the IMF, but before joining the IMF, she was working as a consultant, private consultant, and before that, she was working at the European Stability Mechanism, another international organization, but before, she was working at two private companies, big one, Repsol and Banco Santander. So actually, in her CV, you can find, and you can see, that she has a background in which she has mixed international organizations and governments, and then also private markets. So actually she knows quite well all that has to do with incentives. So we will see the video by Saioa, and then we will have the Dr. Tejada. Dr. Tejada, so let me do this introduction in Spanish for him. By the way, even if now we don't have the translation, later we will all have everything in English and everything in Spanish. So that's going to be fine. Okay, later on. So, el doctor Alberto Tejada Noriega es médico cirujano, fue ministro de Salud y presidente del Consejo Nacional de Salud en Perú. Ha sido 3 veces, durante 3 mandatos, ha sido alcalde electo de la Municipalidad de San Borja en Lima, y también ha sido presidente de una red de municipios saludables a nivel nacional. En la actualidad dirige una institución médica en salud sexual y reproductiva, ejerce su especialidad, que es urología, y conduce un programa de televisión en vivo de salud a nivel nacional en Perú. Él nos hablará después de Saioa. Third speaker is going to be Professor Li Du from China. Professor Li Du joined the University of Macau the Faculty of Law a few years ago, in 2016. He's basically doing research and teaching in international law, health law, biotech law, and policy. And well, he graduated by Wuhan University in China with a dual degree in law and clinical medicine in 2005. And since then, basically, he worked in Canada, and then he came back to China. His research interests are legal, ethical, and social issues related to the cutting-edge biotech, stem cell, clinical applications, and so on. And well, he's also very interested in the mix between health law, older regulations, and new technologies is also something very, very important in this world. Then we are going to have also Mónica Sánchez. Mónica Sánchez es ministra del Servicio de Ecuador, del Servicio Exterior de Ecuador, lleva más de 20 años de carrera diplomática, ahora es la coordinadora política de Ecuador en el Consejo de Seguridad de Naciones Unidas y ha sido coordinadora del Gabinete del Ministro de Relaciones Exteriores y Movilidad Humana. También ha sido cónsul en Argentina de Ecuador y ha desarrollado funciones en la representación permanente de Ecuador ante la ONU aquí en Nueva York. Por ejemplo, como asesora del presidente de la Asamblea General de Naciones Unidas entre 2009 y 2010. Entre otras responsabilidades, Mónica es miembro a título personal del Comité Administrativo y Financiero de la Corte Penal Internacional, de que fue presidenta y vicepresidenta en 2 ocasiones. Afterwards, we'll have David Clarke. He is coming now from Switzerland, but he is from New Zealand. David is the Unit Health Systems Governance and Stewardship Primary Healthcare Special Program. He is from Wellington, New Zealand, and is a lawyer who specializes in health law and policy. David has worked for years at the WHO, and basically he's an expert in many things, but for instance in the work of achieving universal health coverage or using the law to deliver this universal health coverage. So thank you also for this. And we also have Professor Chenguang, that let me get your CV now that I... no, it's let me, because it's not, for some reason, it's not here. I'll give you later the introduction when you are gonna talk, because you will be the last one. Okay. So let's start because I don't wanna miss the time. So let's start with the first presentation by Saioa Armendáriz.
Welcome everybody to this panel on human rights with a particular focus on health. First of all, I would like to thank the organization for inviting me to this Congress. I would have liked to join you in person and share this presentation in live, but some agenda constraints have forced me to record this video instead. Hopefully, we could meet in the future. When I received the invitation, I had my doubts about what a macroeconomist like me could tell professionals focused on the field of the law. However, in nowadays, and considering all the challenges faced by the global economy, I think it could be very helpful to show, through a naive exercise, the quantitative role of qualitative fields, such as access to health, in economic growth. Let me start with some references from the World Health Organization that specifies that the right to the highest attainable standard of health implies a clear set of legal obligations on states to ensure appropriate conditions of health without discrimination. This would include the right to control one's health and body, but also the right to a system of health protection with equal opportunity for everyone. However, several countries have still a long way to go in order to comply with this statement in both advanced and developing economies. And here is where our fields, law and macroeconomics, should be more aligned. I think we would all agree on the key role of public policies in reaching the highest possible standards for citizens. However, all governments usually find a strong limitation on the availability of resources to guarantee the compliance with some basic human rights. Indeed, in a recent report released earlier this month, the United Nations issued a grave warning as global public debt reached an all-time high of $92 trillion in 2022. This surge in public debt levels since the 2000s demands immediate action to face the escalating crisis affecting the global economy, with particular impact on developing economies. As a reference, African countries pay 4 times more for borrowing than the United States and 8 times more than the wealthiest European economies. A total of 52 countries, representing almost 40% of the developing world, are in serious debt trouble. Of special concern is the rapid growth of interest payments surpassing other public expenditures. It is alarming that some governments are forced to spend more on servicing debt than on critical sectors like health and education. Indeed, United Nations shows that at least 19 developing nations allocate more money to interest payments than education, and 45 allocate more to interest than health expenditure. These figures reveal not only a severe humanitarian crisis, but a lack of development from an economic perspective. As I am aware that this is not the main field of the audience, let me simplify the economic rationale of growth and the key factors behind. In economics, we rely on theoretical estimations to assess the impact of reforms and policies on long-term growth, known as potential growth by economists. By potential growth, we refer to the rate of growth that an economy can sustain over the medium term without generating excess inflation, based on its available factors, labor and capital. In addition, economists account for the role of total factor productivity, defined as a measure of productive efficiency that quantifies how much output can be produced from a certain amount of capital and labor. In the particular case of health, we can assume that universal access to health will translate into lower mortality rates and thus higher labor force. In addition, a healthier population will be able to be more productive, translating into higher economic growth. In the same way, a stronger GDP growth will reinforce investors' confidence and supporting a more healthier public finances, all making the economy more resilient. As already mentioned, public debt levels reached an historical high in 2022. I present here the debt projections for a particular country, measured as percent of GDP, to have an idea about the payment capacity of the country, as the GDP measures the production of the economy in 1 year. Let me specify that this data comes from a real DSA exercise done in 2019. This means that the projections were made before the pandemic and the war in Ukraine, and the basic assumptions could be considered as a benign scenario today. We can see that even in 2019, debt projections showed an increasing path of public debt, showing unsustainable dynamics in the long run. As explained in the previous slide, universal access to health and more efficient health systems could support economic growth in the long run. In order to show the quantitative implications of better health policies, I ran a second scenario, assuming higher potential growth and fiscal balance by only 0.2 percentage points respectively. Leaving the implications from a human rights perspective, we can see the relevant change in public debt dynamics that stabilize debt in the long term. During this presentation, I tried to bring some of the implications of universal access to health from an economic perspective. With challenging times ahead, it is key for policymakers to understand the role of developing areas as health on economic growth and its implication on the sustainability of public finances. I hope that as experts in the field of law, the basic exercise performed has helped you to better understand the role of health, not only from a human rights perspective, but also from the economic side. I would be happy to clarify further during the discussion.
It's clear that basically the relationship between the macroeconomic variables and the impact of health system and health expenditure. If we are increasing more our health expenditure, there will be more public debt, but we have to take care of we have to need to raise the concern that sometimes health expenditure is not only expenditure but it's also investment, and then we need to take care of sustainability of health systems, but at the same time we need to give value to all what we are spending in health. So that's basically the main goal. We will have available this video also after the Congress by Saioa. Now our second speaker is Carlos Alberto Tejada. Dr. Tejada, cuando quiera, por favor.
Thank you for the attention. Thank you, President. I speak in Spanish.
Yeah, you can speak in Spanish.
The paper for the presentation for English is I prefer English. Bueno, yo quiero en el ánimo del tiempo, primero agradecerle por esta gentil invitación y transmitirles una experiencia y preliminar acerca de la importancia de lo que es la primer nivel de atención. El derecho a la salud fue establecido primero en la Constitución de la Organización Mundial de la Salud allá en el año 1946. Estipulaba que el goce del grado máximo de salud es uno de los derechos fundamentales de todo ser humano y definía la salud como un estado de bienestar, tanto físico como mental y social, y no solamente la ausencia de afecciones o enfermedades. Esa es una visión muy importante que yo creo que hay que enfocarla porque nosotros tenemos que invertir en salud y no necesariamente en enfermedad. Y para ejercerla no hay realmente un modelo perfecto, ¿no? Para honrar este derecho al acceso a la salud, sea financiado por aseguramiento público o privado, financiado por impuestos, hay modelos y hay motivos, ¿no? Que inspirados por supuesto en la cobertura, en esencia deberían asegurar el acceso oportuno, la protección y una satisfacción global medible, pero no siempre es así. Desde hace más de 40 años, en la cumbre de Alma Ata, se analizó la tendencia hospitalaria de la gestión de salud. Por supuesto, sin desmerecer su enorme importancia en la capacidad resolutiva de la alta complejidad de la enfermedad. Se conoce hoy concretamente que el 70% de la carga de enfermedad, que es lo que cotidianamente la gente padece, se resuelve con eficiencia y en bajo costo a nivel local, porque es aquí donde vive la gente y donde pasan realmente las cosas. Y es que este primer nivel de atención es clave si se fortalece y se hace más racional de esta manera la atención hospitalaria. Pero para eso se necesitan políticas claras y asumir un liderazgo en la gestión de salud territorial. A mi juicio es una política de ganar-ganar. Desafortunadamente, por factores diversos, división política, probablemente de falta de estímulo, de limitaciones presupuestales, de recursos humanos y hasta aspiracionales del recurso humano, resulta difícil su implementación eficaz. Nosotros queremos compartir en estos breves minutos una experiencia exitosa de fortalecimiento del primer nivel de atención que se llamó la ciudad inteligente en salud o el Smart City Hub, que ganó el reconocimiento académico a nivel nacional en Perú, mi país, y también en la Organización Panamericana de Salud como una buena práctica en gobierno y en salud, el cual debería articularse este modelo con una gestión de redes integradas para la referencia hospitalaria cuando las condiciones lo ameritan. Este emprendimiento llegó a tener un 95% de la satisfacción ciudadana medida, por supuesto, y pasó de un 16 a un 78% de cobertura. Literalmente pasamos de 33.000 pacientes a 266.000 pacientes en tan solo un año. Y curiosamente, en la época del COVID, con una de las tasas más bajas del país de letalidad, en una comunidad que es la que yo he tenido la dirección, de 130.000 personas. ¿Qué fue lo que hicimos? En realidad, cambiar paradigmas en un sistema colapsado y trabajar en equipo con el ente rector para gestionar sus políticas territoriales. De hecho, mi experiencia en el ministerio me permitió saber dónde estaban las brechas y con un lema que era actitud, ¿no? Primero comenzamos cambiando la estructura orgánica del propio municipio, ¿no? Porque había que cambiar la estructura orgánica, darle una nueva misión, una nueva visión y obviamente elementos de gestión. Contratar gerentes públicos en salud con una visión de Estado, porque en el territorio normalmente trabajan médicos asistenciales sin una visión de gobierno. Apelar a la tecnología hoy existente, a la Big Data, al análisis de la misma, a la geolocalización catastral, en realidad a la información a la cual alimentamos con un censo sanitario, conformando lo que viene a ser un observatorio en salud, una verdadera central de inteligencia con infraestructura que ya existía para la seguridad, tratando de crear o construir una inteligencia artificial, lo cual nos permitió tener un mapa epidemiológico en tiempo real y validar y corregir la data del Estado, la cual normalmente estaba equivocada, y convertirse en un verdadero centro de operaciones tanto de la oferta fija como de la oferta móvil en salud. Desde la articulación de ambulancias, farmacias al delivery, atención domiciliaria, hasta la provisión de oxígenos en épocas de crisis o la gestión de residuos sólidos durante la pandemia. Asimismo, la conformación de un call center capacitado especialmente para este fin por una universidad, con un número de fases de recordación para la respuesta rápida ante la llamada en salud, la ayuda de la telemedicina y la orientación de determinantes sociales con una visión en realidad 360. Conformamos un comité municipal de salud local conformado por autoridades locales y la participación ciudadana. Y nos pareció que era la pieza fundamental para el empoderamiento sanitario y también la aprobación de un plan de salud territorial concertado pidiendo disponibilidad presupuestal, y eso haría sostenible el proyecto. Igualmente, la inversión para construir y fortalecer un concepto de clínica de familia, un modelo donde se integran todos los prestadores de salud de distintas fuentes de financiamiento, trabajando juntos en un local de la municipalidad para honrar la cobertura del asegurado, la cual tiene existente. En mi país funciona el modelo de aseguramiento, no hay un modelo por impuestos. La idea es atender a la gente con calidad, con calidez y sobre todo aprovechar de la cercanía. A su vez, facilitar la articulación intersectorial de determinantes sociales de la salud y de priorizar la promoción y prevención que normalmente está desfinanciada porque existe una, pero es muy genérica y se inspira usualmente más en el auspicio de la enfermedad que en la fuente propia de la salud pública. Por último, realizamos alianzas académicas para la investigación del modelo, involucrando pasantías universitarias para realmente hacerlo esto más sólido. Esta iniciativa en curso pretende ser un modelo de salud pública de precisión, a semejanza de lo que hoy día, por ejemplo, existe en disciplinas como la oncología, y se propone asumir con responsabilidad la protección social de su comunidad, pues la conoce cercanamente, así como sus complejidades y singularidades que en muchos casos hay, y apela a la tecnología existente y, por supuesto, a través de alianzas estratégicas en todos los niveles hasta la participación ciudadana, conocedores que el sector, en este caso el sector de salud y el gobierno, se enfocan en la gestión de servicios y solo en la atención de enfermedades. La biología, el medio ambiente, los estilos de vida tienen un impacto muy rentable realmente en la salud y su eficacia va a depender desde alfabetizar en salud a la población hasta velar por la nutrición, luchar contra la obesidad, contra el hacinamiento, velar por la buena higiene, la calidad del agua, los servicios básicos, la gestión ambiental, la calidad del aire, los residuos sólidos, la violencia, la inseguridad, las adicciones, la salud mental, la protección de la población vulnerable, hasta la recreación y la actividad física en espacios seguros y accesibles. Ninguno de estos componentes son propios del sector salud y, por supuesto, nuestro objetivo principal es empoderar a la colectividad de la promoción y la prevención en salud, y esto literalmente es más rentable. Ejercer plenamente el derecho a la salud y al bienestar, como lo suscribe la Constitución propia de la Organización Mundial de la Salud. Muchas gracias.
Muchas gracias, Dr. Tejada. So, basically, let me give a summary of what Professor Tejada, well, Dr. Tejada was presenting today. So basically, he was talking about how in Peru there are lots of difficulties of getting indicators, health indicators that are useful for managing the practice of medicine and the access to services. He started stating basically the definition of health that came from the WHO more than 50 years ago, and how this definition has been evolving in the last decades. Then he has a very strong experience both at the country level but also at the municipal level. In the last years, basically what he was explaining is his experience at the municipal level in a population of 130,000 people, basically, first thing they needed to do was to change the management of and the structure and organization of all health policy making, and the next thing was to hire new public health managers, and then they started doing very interesting things like adding innovation, like for instance the use of technology and information, and they created a very important observatory in health in which they could have more information in real time, in real time basically, of all the offer of services that they could manage for their population. They also implemented a call center in which they were taking care about all the social determinants, and he was talking about the importance of these inequalities in socioeconomic characteristics of the population, and and then also with the creation of a committee of mental health. And one of the points in which he was remarking most was the importance that they were providing to the participation of the population in all the decisions. So basically, that's going to be very important, not only for the provision of healthcare services, but also for the prevention, taking care of the changes in the lifestyle of the population in order to prevent for further need of services. So that was basically the most, basically a summary of his speech, hopefully. So next speaker is Professor Li Du from China.
Thank you so much, Manuel, for sharing this session. I'm also very happy to share some of my thoughts on. I don't think it's working.
Should be working.
Is it working?
Yeah, hopefully.
Okay. And share some of my thoughts about use of the new technologies for dealing with the challenges of the pandemics, and how balanced the risks and the benefits brought by these new technologies in the context of fighting against the pandemic, as well as the purpose of public health surveillance. So during the pandemic, COVID-19, that we've seen a lot of new technologies has been applied. So these technologies, the use of these technologies help to provide a sufficient control, and also sufficient control of the spread diseases, and also to contain the spread of the diseases. It has been shown that these tools has been effective, but also there are some risks and also concerns raised by the general public. So today I'm going to share with you two examples by using tracing apps and also facial recognition technologies, two case studies to show that how these tools work and what are the concerns that may be raised based on the use of these technologies, and also give some insights from the audience that how we can solve this problem out. So first is I'd like to share with you is the use of tracing apps. So this is very widely adopted at the beginning of the pandemic, in I think majorly in 2020 and 2021. So these type of apps can trace the movements of confirmed and suspected COVID-19 cases and their close contacts. So based on the different technologies being used worldwide, these type of apps can provide users with infection risk level information specific to their communities, and notify users who have been exposed to the COVID-19. And so based on these functions, that the public, social organizations, and the governments can better prevent and control the pandemic. So different technologies has been used, like the Bluetooth, GPS, and other types of technologies. However, we found that, this is what we also published in an article on this, we found that these apps actually developed by different countries, different regions, and even within a country, different states. And also, the different countries and jurisdictions have different laws on data protections. Some of the countries have data protection laws, but some of the countries don't have. So here raises an issue. When the international travels resume, that's what we happen today, such kind of apps may lose its efficiency in dealing with fighting against the pandemic. And we've seen that. It's also recently published in Nature journal that tracing apps helps and increase indeed the efficiency of controlled pandemic as well as the containing of the spread of the diseases. However, so here what we need to consider is how we can deal with this type of insufficiency because of the legal challenges and the legal hurdles. So these apps works within the country, but once it's becoming international travels, then all those type of apps becoming isolated and lose their abilities to trace and monitor the spread of pandemic in cross-border travels. So we're thinking that probably we need a consistent international efforts to be devoted into developing an international data sharing platform for global pandemic control and remove the legal barriers that hinder the interoperability of tracing apps technologies. And all of these efforts actually aimed to contribute in better response or smarter response for the potential future global and health crisis. So this is the one thing, one case I want to share with you, talking about what we need to do at international level. The other one is the facial recognition technologies. So during the pandemic time, we've seen this type of applications that's used in some countries, not every country, some countries. For example, like in China, that we had like the facial recognition technologies and the temperature measuring machines being integrated into the access control systems in many residential buildings and communities in China. So by using these type of technologies that the people can go in and out of communities without even touching any devices and even with wearing a mask. Other than community entrance control, facial recognition technologies has been widely used in access control systems at Chinese hospitals and the public transportation terminals. And in addition to automatic measurements of body temperatures and facial verifications, the systems also being used in public spaces, which were able to scan the health QR code. This is the kind of code developed by the Chinese health agencies on the mobile devices. And also the system can indicate if the person didn't wear the mask, there's a warning sign they should put another mask on. So that's the enforcement of mask mandate. We've seen that these type of technologies has been increasing efficiencies in terms of effective pandemic control, especially given the big population like the country in China, we have a crowded population. But also concerns related to privacy and data protection rights and also other fundamental rights have been raised by the general public. So in terms of privacy, concerns about the use of facial recognition in public health surveillance resolving around its potentially extensive impact on the citizens' privacy, especially given that a huge number of individuals whose personal data are collected and processed. So these concerns has been raised by the public in both like in China and other jurisdictions like European Union. So facial recognition is potential attack the people's privacy in different ways. So firstly, that it can be traceable, right? It tracks the individual's movements and activities without their knowledge or even consent. And also the facial recognition can be used to collect and store biometric data like the facial images and the temperatures without individuals' consent. So without proper consent and regulation, these can lead to potential abuse, misuse, or an unauthorized access to sensitive data. And also there are concerns about data protection rights, because in these jurisdictions we've seen the establishment of personal data protection laws, but how to make it compliance with these regulations seems like a kind of challenging. So for example, in China and the European Union and also in Macau, the personal data protection law requires that if you use these technologies, you must gain specific consent. However, for this massive monitoring, it is very difficult to gain really like the specific consent, explicit consent on using this kind of data. And also, data protection laws establish the special conditions for using sensitive data like the facial images. So this is also the kind of challenges to make it compliance with the law. Another issue is about the data subject rights. So this is general rights that are granted by personal data protection laws that the data subjects has the right to information, access the information, knows who collected, what data collected, how it is shared. But for these massive monitor technologies, it's difficult to notify individual that how your data are being used. It's another challenge. And other fundamental rights, including possibilities for infringing freedom of speech and the general freedom of behavior, is another concern, because if people know that they will be monitored by these technologies, they may be less likely to express their opinions or engage in certain behaviors for fear of being identified or tracked. And also because facial recognition technologies sometimes may occur mistakes. So these generates another issues about being treated incorrectly or being discriminated because of using these technologies. So here what we need to consider for this specific use of the technology is we know that this technology can bring some benefits for better or smarter control of epidemics, but also it may bring the risks we just explored. Then can the use of facial recognition be justified by public health surveillance purposes? As probably David may cover that public health has been widely recognized as a legitimate ground to limit fundamental rights and human rights. And also according to WHO, that states are obliged to develop appropriate, feasible, and sustainable public health surveillance systems. Under these obligations, the use of digital tools like the facial recognition may be considered necessary and legitimate to control epidemics. However, how to balance these two, the benefits and the risks, really need discussion and debate for preparing a better and also smarter control of epidemics in the coming years. We've seen that to address these complicated issues, it is really important and crucial to engage in transparent and also inclusive public discourse involving experts, policymakers, civil society organizations, and lawyers, ethicists, to be discussed in a group and together, because these technologies affect not only individuals but also the entire societies. Some groups get the benefits, some groups suffers from the risks. So it is important, I would say, at domestic level to get this type of public engagement and discussion about how we can establish the proper rules to regulate these technologies. So these two examples I'm sharing here. So one is to highlight the importance at international level that what international communities should put our efforts to promote the use of the technologies by reduce the legal hurdles in terms of data sharing and the data transfer, and also at the domestic level that how we should deal with the use of these new technologies to fighting against the public health crisis on the one hand, and on the hand to promote and to protect the values we view important in our society. This is what I'd like to share with you. Thank you so much.
Thank you very much. So let me give a brief summary in Spanish of what you said. El profesor Du básicamente lo que nos ha estado contando es el uso de las nuevas tecnologías durante la pandemia, ¿no? En el caso de China, ¿no? Con la experiencia que él ha visto. Entonces, está claro que las nuevas tecnologías sirven para controlar a la población y para contener una expansión de una enfermedad, pero a la vez también está claro que tiene unas contrapartidas, ¿no? La contrapartida que tiene que ver sobre todo con la restricción en los derechos que pueden tener la población. Entonces, él habla sobre todo de los datos, ¿no? Habla de las apps, de las aplicaciones de móviles que controlan la ubicación de las personas, que eso está muy bien de cara a controlar la enfermedad, pero también dice una cosa muy interesante, y es que diferentes países tienen diferentes regulaciones y tienen diferentes aplicaciones, y esas diferencias en realidad nadie ha contrastado cuál es el modelo más eficiente de si debería ser esta app o esta otra con una regulación o con otra, ¿no? Entonces quizás habría que hacer algún estudio un poco más interesante o más intenso sobre cómo deberíamos tratar ese trade-off o esa tensión entre derechos y la expansión de la enfermedad, y de hecho probablemente deberíamos tener una regulación global mucho más internacional para un problema que ya de por sí era un problema global, ¿no? En lugar de que en cada lugar tengamos una regulación un poquito diferente. Habla sobre todo de dos tipos de lo que es, habla de la ubicación por un lado, pero también luego habla del control de temperatura corporal y del reconocimiento facial, ¿no? Y que toda esta información se estaba recabando sin el consentimiento de los individuos, ¿no? Entonces, claro, el problema es si debemos hacerlo o no debemos hacerlo en función de la importancia que le estemos dando al sistema público sanitario, ¿no? Si el sistema público sanitario sí tiene la justificación de hacerlo sin ese control o sin ese recabamiento de los consentimientos de todos los ciudadanos. Y también habla del derecho a la libertad de expresión, porque también se ve coartado cuando la población puede sentir que se le está controlando con las imágenes, etcétera. Entonces, que también podría haberse coartado ese derecho a la libre expresión. En definitiva, él lo que dice es que lo que tendría que estar ocurriendo es que está claro que hay una tensión entre control de la enfermedad y derechos fundamentales, y quizás lo que tendríamos que intentar es tener muchos más agentes involucrados, pues la población, los políticos, los gestores, y que tendría que haber distintos stakeholders que participaran en esas decisiones sobre cómo tendríamos que diseñar estos sistemas. Thank you very much, because it was really interesting.
Thank you so much. You did a wonderful job. Translate all these presentations.
Just trying.
Thank you so much.
Just trying. So our next speaker is Mónica Sánchez from Ecuador.
Thank you very much, Manuel, and thank you for inviting me. I think that in name of gender parity, it's good to be in this panel. Also, it's important that gender should be always the focus of all the initiatives in health, because we are always the most vulnerable in most of the health issues. Now I am going to switch to Spanish because I prepared in Spanish and it is very technical, so I feel more comfortable.
I will.
So thank you very much. Bueno, cuando enfocamos el tema de derechos humanos y acceso a la salud, parecería que hablar de salud mental es algo obvio, ¿no? Sin embargo, no es así. En el mundo se conoce que millones de personas sufren de algún problema de trastorno mental que imposibilita tener una vida plena. La OMS, por ejemplo, advierte que debido a varios factores de estos últimos años, las enfermedades por salud mental o la enfermedad por salud mental será la enfermedad no transmisible más alta en el mundo en el año 2030. En este escenario, aún para muchos países, por ejemplo como para Ecuador, el hablar de acceso a salud mental, a una cobertura de salud mental o incluso contar con ayuda profesional para ello es casi impensable. La COVID-19 efectivamente agravó muchísimo las enfermedades mentales, como los trastornos bipolares, de ansiedad o depresivos. Se tiene que más o menos un 27.6% habría sido el incremento de los cuadros de bipolares o de ansiedad durante la COVID-19. Y durante los 2 años de pandemia, estos 2 años sumieron al mundo en situaciones marcadas por la incertidumbre, el miedo a la muerte, el no poder despedir a los familiares, el estar con falta de contacto, la violencia intrafamiliar, entre otras que estoy seguro que todos la sufrimos durante la pandemia y que nos sentimos muy familiares con estos cuadros. La mayoría de estas enfermedades, como dije al inicio, tuvieron una afectación directa a mujeres y a niños. Esto sin contar con los cuadros de salud mental que vivió el personal sanitario debido al desgaste emocional y al estrés postraumático, pero sobre todo aquí podemos ver esto que hemos estado comentando en este panel tan interesante, que es la imposibilidad del sistema sanitario a hacer frente a este tipo de problemas. El personal calificado para atender los casos a tiempo fue mínimo y se estima que, de acuerdo a las cifras de la Organización Mundial de la Salud, 93% de los países del mundo paralizaron sus servicios de salud mental debido a la falta de personal y a la cantidad de casos que había en ese momento. Además de la pandemia, digamos, termina la pandemia y entramos en un conflicto todavía mayor, que es un conflicto internacional, una guerra de gran magnitud, que no solamente afecta a los territorios que están en guerra, sino que tiene consecuencias económicas y que el mismo sentido de seguridad pone de nuevo esta tensión en la salud mental en el mundo. Esto sin contar con aquellos países que han estado en conflicto durante décadas y donde se cometen violaciones inimaginables de los derechos humanos a diario, que marcan en los trastornos mentales no solamente en esta generación, sino de aquí a muchísimas generaciones más, porque además, de nuevo, el sistema ha fracasado en la posibilidad de tener el acceso o la posibilidad de dar ayuda a las personas que así lo necesitan. Yo les podría decir, por ejemplo, en el Ecuador, nosotros hemos recibido una cantidad enorme de refugio, de personas en refugio, y uno de los problemas que se tiene es justamente el acceso de estas personas que vienen en refugio, que están en desplazamiento, que vienen con una movilidad humana complicada, a un país que ya de por sí la cobertura de asistencia en salud mental es mínima. Tener nosotros que también hacer frente a esta situación, que es una situación de emergencia y que se debe dar atención porque es el derecho de esas personas de contar con ello. Asimismo, otro de los factores muy fuertes que está teniendo el mundo es el consumo de fármacos, ansiolíticos y drogas. Según la Oficina de Naciones Unidas para la Droga y el Delito, en el informe del 2022, detalló que 284 millones de personas entre 15 y 64 años consumen drogas. Esto significa un 26% en el aumento del consumo de drogas de la década anterior, ¿no? Teniendo obviamente como resultado de nuevo un proceso de, digamos, de deterioro en los temas de trastornos y salud mental. Sin embargo, y viendo todos estos cuadros, todos estos problemas, la posibilidad de que en un futuro la salud mental venga a ser la enfermedad más alta no transmisible en el mundo, la Organización Mundial de la Salud demuestra, y esto voy a repetir quizás algo que Saioa lo dijo muy interesante, el gasto en los servicios de salud es mínimo, menos aún en salud mental. Solo para darles unos datos, lo que gasta el mundo en salud mental es del 2.8% de sus presupuestos de salud, es decir, mínimo. Se prevé que los países de ingreso bajo gastan alrededor de 0.5% y los países de ingreso alto apenas del 5.1% del presupuesto de salud. Más preocupante es que los tratamientos y cuidados sigan siendo absolutamente escasos, inaccesibles o demasiado caros. Y la estigmatización que existe por el tema de trastorno y salud mental es todavía muy alta como para que los países realmente definan y tengan en cuenta la importancia de dar acceso a este tipo de salud. Existe un déficit de tratamiento que alcanza el 90% en algunos países y trastornos ocasionados, como dije antes, por temas del consumo de drogas. Esto lo que hace es convertir a la salud mental en un privilegio en lugar de un derecho. La comunidad internacional a través de la diplomacia ha tratado de generar un debate, un interés sobre este tema de salud y salud mental. Podemos iniciar, por ejemplo, en 1948 con la Declaración Universal de Derechos Humanos, que establece en su artículo 25 el acceso y el derecho de acceso al tema de la salud. En 1966 se reconoce el derecho a la salud mental en el Pacto Internacional de Derechos Económicos, Sociales y Culturales en su artículo 12º. En el 2017 el Consejo de Derechos Humanos de Naciones Unidas aprueba una resolución sobre salud mental y derechos humanos. Y no voy a seguir citando instrumentos, pero nada más quiero poner en la mesa que existe la suficiente normativa y la legislación tanto internacional como nacional. Por ejemplo, se ha visto que a partir justamente de que estas resoluciones o declaraciones sobre derechos y el derecho a la salud y el derecho a la salud mental permite que haya un tema vinculante para los estados, y los estados incorporan en sus constituciones. Tenemos que son 115 las constituciones nacionales que ya incorporan el derecho y el derecho de salud mental en sus constituciones. A pesar de esto, vemos que aún la cobertura y el acceso son mínimos y son algo impensable en la mayoría de los países. Digamos, algo que se viene es en septiembre de este año, en las Naciones Unidas se van a llevar a cabo la reunión de alto nivel sobre cobertura universal para la salud. Ahí se espera adoptar una declaración en la cual se asegura que nadie quede atrás, es decir, que se respondan a las necesidades de salud física y mental equiparadas, y que se promuevan los derechos humanos, la dignidad de las personas bajo principios de igualdad y no discriminación, en especial con un enfoque de nuevo al tema de género y al tema de los más vulnerables, que en este caso son niños, jóvenes, personas con discapacidad. En el Consejo de Seguridad, les voy a dar un ejemplo, se incluye ya la salud mental como parte de los mandatos que se están dando a las operaciones de paz o a las misiones políticas especiales y a los operadores de paz, con el objetivo de que puedan tener la capacidad de enfrentar las situaciones que conllevan los conflictos, sus consecuencias, y apoyar a la regeneración del tejido social que está absolutamente destruido, para así lograr procesos de reconciliación con la idea de tener una paz duradera. Como decía, no existe, a pesar de tener marcos normativos internacionales y nacionales, es importante quizás tener algunas estrategias a futuro. La primera es generar datos. Los estados no tienen suficiente data, los organismos internacionales de la salud como la Organización Mundial de la Salud tampoco los tiene, quizás por esta estigmatización del tema de la salud mental, que no es fácil para todos aceptarlo, o quizás por falta justamente de presupuestos. No existen los datos para que los estados, por ejemplo, empiecen a consolidar planes que respondan realmente a la problemática de salud mental. Segundo, garantizar que los estados inviertan en atención a salud mental, incrementar los centros de atención, los profesionales que permitan hacer frente, como por ejemplo lo que nos explicaba Carlos Alberto, que me parece interesantísimo, y la necesidad de que todos los actores sean parte justamente de esa garantía. Incluir en todos los programas de atención a la salud mental una perspectiva de género, considerando que son las más afectadas. Deben ser priorizadas los más vulnerables, las víctimas de violencia, las víctimas de acoso sexual, las víctimas de acoso escolar, migrantes, personas víctimas de trata e incluso los privados de libertad. Pero sobre todo es necesario trabajar en campañas preventivas. Los datos confirman la urgencia de destinar más recursos a prevenir problemas de salud mental desde edades tempranas, en especial a desestigmatizarla. Para ello es imprescindible contar con el sector privado en todos estos esfuerzos y apoyar las campañas de prevención desde todas las esferas, incluso desde las esferas de trabajo y desde las esferas de las empresas privadas. Recordemos que las obligaciones de los estados en temas de derecho a salud son 3: respetar, proteger y cumplir. La salud mental no es tangible y por ello está invisibilizada, pero sin embargo es una enorme problemática que plantea un futuro casi incierto para la sociedad y el mundo. Gracias.
Bueno, muchas gracias, Mónica. Muchas gracias. So, I'm going to try to translate to English a brief summary of what Mónica was saying. Basically, she was pointing to the situation that after the pandemic, basically there has been a lot of changes in the needs of the provision of the mental health care of the population. she was talking about the reality of the provision of mental health care, which is not there. Basically, we are lacking we are lacking mental health services, access to mental health services in a historical moment in which we actually need much more than earlier. After because of the pandemic and because of many other reasons, but also because of the pandemic. So basically, she was saying that mental health is supposed to be by 2030, if I'm not wrong, the most important non-communicable disease internationally, and there is going to be an increase of more than 30% in the next years. So and there has been an increase of 30% in the last years because of the pandemic also. There were lots of uncertainties in the population. There was because of the pandemic isolation of the population. All those factors were increasing the need of mental health services, and also intrafamilial violence that also increased a lot during the pandemic, especially for the vulnerable population. She was marking this quite a lot, that women, children, and all the vulnerable population was suffering as usual, but much more than the rest of the population. And something quite important, she was pointing out that health systems usually are incapable of providing care for everyone, especially in the case of mental health services. And that's quite important to be, to make sure that we know that, so that we can actually try to solve this problem. She was also talking about the increase in the use of drugs in the population in the last years. That's going to bring new problems of mental health in the future also. And at the last part of the presentation, she was pointing to some solutions, something that could be done by different governments trying to implement to improve basically the access to mental health services. And she was pointing that there is a very low proportion of the GDP that is devoted to health expenditures in some cases, but specifically for mental health services. With a very low, and the result of this small proportion of the budget for mental health services is that the access is really low, with a deficit of 90% in some scenarios in some countries. She was also saying that there are lots of international regulations, international declarations, that, like through the UN, for instance, or WHO, or different international organizations that are trying to help. So basically, the regulation is there. Many countries are actually taking these regulations to their regulation in the country, but still that is not being enough. That is not enough, and the countries are not still acting in order to favor the access to mental health services. And basically, the points that she was mentioning, try to improve the situation, would be that we should try to avoid this lack of data in mental health that we have. That is definitely not helping. We should maybe have more investment in the provision of mental health with more participation also, like Dr. Tejada was mentioning, of different stakeholders, take into account the gender inequalities and the vulnerable population, especially, and like also something that Dr. Tejada was mentioning, we need more prevention. So basically that's a summary, hopefully, of what she was explaining. Thank you very much, Mónica. So next speaker is David Clarke from WHO. Very interesting also what you have to say about all this.
Thank you, Manuel. I think I'll probably touch on many of the points that the other speakers have spoken about. And I'd like to start with what Mónica said, because during the pandemic, I think the right to health wasn't observed. Unfortunately, many countries had to focus on addressing the immediate risks associated with public health. And we saw that essential health services fell away dramatically. Almost every single country in the world had struggled to provide essential health services, especially to women and children. So this has been a big problem for a long time. And I think one of the issues for us is, for a long time we've spoken a lot about the right to health. I worked for an organization that was founded based on the right to health. But in terms of our ability to implement this right in practice in many countries, the situation is quite inconsistent. What we've been trying to do in my team at WHO is to advocate more for why this is an important topic. So we have produced materials which focus on how law contributes to universal health coverage. We've looked at how law specifically relates to health, because in many cases people don't understand the important role of law in relation to health. And turning to the topic that we're interested in today, we've looked specifically at what it means to have access to health services and what it means to have a legal right to have access to health services. So when we started this work in 2019, we did a survey of some of the OECD countries to look at specifically at what they were providing in terms of access to health services. And to help us with this, for the first time we tried to elaborate on what we meant by this. So we looked at whether or not countries had in their legislation the right to health, whether they'd actually operationalized and implemented the right to health in their legislation. We looked at whether or not they had statutory health insurance schemes. We looked at whether or not they were covering all population groups. And what we found in the European region in particular was they weren't. That often migrants and refugees and particularly those people who are not legally recognized in the system are not covered. And that's even in European countries. Interestingly though, in the cases where they are covered, it's usually for public health reasons, because they're worried about migrant populations causing diseases. So they are covered for those things. But when it comes to the access to the services they need, be it mental health services or other services, they're often excluded. The other area that we looked at was the whole area of discrimination. And in many countries there aren't laws which prevent discrimination when it comes to accessing health services, and many populations again are excluded. And we also find that in most countries there aren't any legal rights there aren't any legal complaints mechanisms to enforce these rights. So this is a really important question. It's all very well having rights, but then you have to have the basis to claim those rights. More recently, we've moved and are now looking at countries in our African region. So we have a project at the moment when we are looking at how these countries are doing when it comes to legislating for these rights. And again, the situation is quite uneven. So some of these countries have legislated for the right to health in their constitutions or in their health laws, but many of them haven't. In fact, the majority haven't. When it comes to questions of discrimination, again, some of these countries have included non-discrimination provisions in their laws, but many haven't. When it comes to recognizing legal personality, this is a very important area. It's actually mentioned in the SDGs. There's a specific SDG target about giving people legal personality. Many people don't have legal personality in these countries. So that is their legal personality is not recognized, and therefore they can't claim rights. So this is another really important area that we need to focus in on. We also found that when it comes to new technologies, that this is an area which has become like the Wild West. You see that the private sector in particular and technology companies are moving fast when it comes to digital technologies. It's exploding. You see in the African countries the growth of digital pharmacies, the growth of digital health insurance schemes, but they're often not regulated. And what we found with our study was that in many countries in Africa, and I suspect in some European countries, high-income countries as well, the regulations when it comes to digital health are woefully inadequate, particularly when you think about whether they should be focused in on the right to health. Another area which I'm not directly involved with, but other colleagues are involved with at WHO too, is the whole question of artificial intelligence when it comes to the right to health, and the use of algorithms to make decisions about health allocation of resources. These are two really important areas that, again, we're not really paying enough attention to when it comes to making sure that the right to health is reflected in appropriate regulatory and policy frameworks for all of these areas. And just to conclude, I think one of the big challenges that we have, particularly in low and middle income countries, is the question of capacity when it comes to making laws. I've been working in many different countries over the 20 odd years I've been working as a health lawyer, and my observation is that the high-income countries are often well served when it comes to lawyers who know about health and know how to make health laws. But the low and middle income countries are not. they tend to copy other countries' laws, which might not necessarily fit with their circumstances. And so we have this big capacity issue when it comes to making law and policy in specific contexts, which makes sense for those contexts. So I'm a bit gloomy, I guess, but I think there are two big issues for us. We have a problem with institutional frameworks when it comes to laws, and it comes to making sure that people have access to health rights. But we also have a capacity issue in many countries about how we can do something about this, both in terms of making the appropriate laws, but also providing people with the right to redress. It's not all doom and gloom, though. I mean, a lot of countries are trying to make a difference in this area, and it's heartening also to see the growth of legal NGOs who are trying at the grassroots level to try and make a difference in terms of people's right to access health services. But I think we have to do a lot more. Otherwise, the issues that we've been speaking about around this table will not be addressed. Thank you.
Well, thank you very much for this very interesting presentation. So I'm going to try to translate into Spanish what he said.
Okay, wait.
So basically, perdón. Lo primero que Dave estaba mencionando es que los problemas que tienen los sistemas sanitarios no solo para proveer los servicios de salud mental, sino en general para todos los sistemas sanitarios y todos los servicios de salud. Y es que ellos en la Organización Mundial de la Salud ya han visto cómo la regulación sí puede ayudar tanto a expresar el derecho a la salud como el derecho al aseguramiento, como distintos derechos. Lo que pasa es que de tener los derechos o después que se apliquen a que se vean efectivos, pues va un tremendo mundo, ¿no? Y tienen un estudio en el que estaban mirando básicamente en distintos países en qué estado estaban, si tenían las leyes o si no las tenían, si aparecían esos derechos en sus constituciones o no, y después si finalmente hasta qué grado se estaban dando esos derechos o se estaban ejerciendo esos derechos. Habla también de otro problema enorme, que es el de la discriminación en el acceso a los servicios de salud, y es que expone cómo en distintos países ni siquiera hay mecanismos que obliguen a evitar ese tipo de discriminación en el acceso a la salud. De hecho, comenta que algunos países ni siquiera tienen en sus constituciones el derecho al acceso a la salud, el derecho al aseguramiento o incluso, que es todavía más grave, la personalidad legal de los individuos. Entonces, si hay algunos individuos que ni siquiera tienen una personalidad legal, ese problema es todavía más importante. Después cambia de tema y empieza a hablar de las nuevas tecnologías y cómo en algunos lugares, en algunos países, realmente hay una ausencia total de regulación en el acceso en todo lo que tiene que ver con la salud digital, ¿no? Lo que llamamos como salud digital o el aseguramiento de salud digital, farmacia digital, las compras de medicamentos, etcétera, ¿no? Entonces hay un montón de temas que no están bien regulados, sobre todo en países en desarrollo, ¿no? Habla también del uso de algoritmos y de la inteligencia artificial en la toma de decisiones médicas, que, claro, hay que ver qué es lo que piensa cada uno de los stakeholders, ¿no? Cada uno de los agentes. Están los aseguradores, que pueden tener, digamos, unos incentivos marcados, pero hay que tener en cuenta también el financiador, los pacientes, cualquiera de los agentes. Y finalmente comenta cómo normalmente en los países de renta alta, de nivel de renta alta, normalmente sí disponemos de regulaciones y leyes para asegurar tanto el derecho a la salud como el derecho al aseguramiento y normalmente a la provisión sanitaria, pero que en los países más pobres o países en desarrollo lo que está ocurriendo es que ni siquiera tienen ese marco legal, y cuando lo van a adoptar lo que hacen es muchas veces, en lugar de desarrollarlo ellos, copiarlo directamente del de otros países, y entonces no necesariamente viene adaptado a sus necesidades. Es cierto que hay organizaciones no gubernamentales que están intentando ayudar, pero definitivamente también comenta cómo todavía hay que hacer muchísimo más en este aspecto. I hope that was your...
I'm sure it was
you
great.
can control afterwards. You can control of my translation. You can control afterwards when you look at the video. So later you can you can argue with me. And finally, our last speaker. Yeah, we have time. No worries. If we are late, we are late. I can take the argument from the organization. No worries. So, Professor Chenguang. Yeah, Professor. well, let me introduce you because earlier I couldn't, so because I didn't have everything in my file. So, Professor Chenguang Wang, he's professor of law. He's director of the Health Law Research Center at Tsinghua University. He's member research consultant committee of China Medicine Academy, deputy chair of China Health Law Research Association, and he's also member of the consultant committee on pandemic prevention and control at the China National Health Commission. So thank you very much first for being here and for your presentation. Thank you very much.
Thank you, Chair, and all the colleagues. I don't think we have too much time, so I just
Take your time.
the formal part, just touching on the keynotes I want to address. And previous speakers already talked about the impact of pandemic on the society, on the national health system. And also, I would like to draw your attention to one particular theoretical but also practical issue, which is the highest attainable right, attainable health is the fundamental right, which is written in the WHO Constitution and has been enshrined in many constitutions in the world, same as in China. But when we talk about human rights, we often consider this is a monolithic concept, but actually human rights contains a number of different specific rights. Health, right to health, is actually one of the fundamental rights, which has been already illustrated by the WHO Constitution. But as a matter of fact, people like me working in the law school as a lawyer, very few of them are interested in such important field. As David already mentioned, in many constitutions, well, there is a right to health, but in many countries, how to enforce this right to health is problematic. So that actually becomes a specific theoretical and practical issue. What is the position or function of right to health in the whole bunch of human rights? This is a collective concept of human rights. But within this collective concept of human rights, there are different rights. Professor Lee already talked about pandemic situation in China, and a lot of facial image recognition and, well, kind of high-tech try to trace up people where they are lost. And this is a legal kind of contention or challenge. What is the right to health vis-a-vis right of free movement, right of vote, right of privacy? So here we can see actually we're talking about human rights, but actually within the concept, the big concept of human rights, there are different sides of specific rights. And these specific rights may create rivalries, contentions within the big concept of human rights. So here is, I want just to be very brief, it's a key issue for legal professionals as well as for medical professionals to come together to discuss. As WHO's constitution says, highest attainable health is a fundamental human right. It's such a fundamental right during the pandemic, whether we should put the right to health on the top of the priority of all the strategic plans of the nation. So China, we have to say, health is number one. And all the other benefits, economic benefits, benefits of participation in the society are zeros after one. If you have one, you have economic benefits, you have 10. If you have social participation benefits, you have 100, and you can add numerous zeros. But the fundamental thing is one. If one has no health, as well, situation during the pandemic, in many countries we saw the situation that quarantine is the most effective means to control the spread of the pandemic. Why is that? We do not have effective drugs. We do not have perfect vaccines. And what is the most efficient means to control the disease? Wearing the personal protective equipment, masks, very simple, to reduce social gatherings during the high days of the pandemic. So it depends on the natural disappearance of the virus, which sometimes happens, sometimes not. So quarantine, namely a kind of behavior pattern change, is the most sufficient means to control the pandemic. While you try to change people's behavior, such as in China, when people gather together, we have a common dish. People, everyone at the table will pick up with chopsticks from the dish. Nowadays, the government and society advises that we use a common chopsticks. So there's a common one, you have your individual one. So this is actually changing people's culture pattern, behavior pattern. That depends on the law. I remember on the first day of the pandemic in China, the health commission called me. I said, well, I am not, well, a physician. I don't know, I know nothing about health issues. And the director of the Legislative Affairs Bureau said, okay, we want you to conduct an immediate and quick research. There is a kind of notice in front of every station of subway, which says, without masks, you cannot enter. People are gathering and debating if there is a law. They asked me to quickly assemble a group of lawyers to give a legal answer. So we searched all the, well, laws and regulations, regulation on privacy, and regulation on emergency, and also all kinds of health laws. And we finally come to a kind of suggestion that it is the duty of the government to protect every individual's health. If you have the kind of information that the virus is deadly and causing enormous harms and damages for individuals, the government has the obligation to make a public announcement, to give advice. And at the same time, you should also go through the legal procedure and find the legal foundations, trying to make a proper, not excessive control of people's behavior. So that's one of the examples which illustrates all the legal professionals and the medical professionals will face a kind of challenge. Within the concept of human rights, in different times, particularly during the emergency of the pandemic, whether we should put the right to health on top of the agenda. Namely, for the sake of people's health, we could temporarily curtail other kinds of rights. The right of your business. So a lot of small businesses have been shut down, but temporarily. And this is the one key theoretical and practical issue. And secondly, what are the conditions for you to make very strong, let's say, kind of regulation of this behavior? What is the time for you to make a policy shift to loosen up this kind of rigid control of the people's behavior? I think actually this is a kind of question and facing every nation, every country, and WHO certainly needs to come up to give advice. And what is the position, the function of right to health vis-a-vis other kinds of rights? So
Thank you very much, Professor Wang. Muy breve en castellano lo que nos ha contado. Básicamente la ponencia del profesor Wang ha sido muy práctica sobre que los derechos humanos son muchos derechos humanos, pero el derecho a la salud es uno de ellos, pero en realidad lo que realmente habría que ver es cuál es el papel que tiene cada uno de ellos dentro del conjunto de todos los derechos humanos, ¿no? Y que es muy problemático ser capaces de articular ese acceso a la salud como derecho humano dentro de todo el resto de derechos humanos. Es verdad que se han restringido movimientos, privacidad, es verdad que durante la época de la pandemia en muchos lugares del mundo, desde luego también lo comentaba en China después de la ponencia del profesor Du también. Entonces, eso es cierto que ha ocurrido, lo que pasa que también habría que ver si se establece que el derecho a la salud es el primero de los derechos fundamentales, entonces todos los demás lo siguen y necesitamos tener salud para después tener el resto. Entonces, de alguna manera lo que estaba comentando es que se priorizó uno de esos derechos fundamentales, que es el derecho a la salud, para después tener el resto, aunque sobre todo en un momento en el que no había medicamentos, vacunas efectivas, etcétera. Entonces se usó la cuarentena con esa reducción de los derechos, que también sirvió y que el gobierno también tiene que servir para proteger a la población y para dar información a la población y para cambiar hábitos, como pues algunas costumbres que comentaba que fueron cambiadas de estilos de vida. Y es cierto también que en esa restricción de derechos también hubo un montón de negocios, por ejemplo, que cayeron, que eso es un coste de la pandemia, pero lo comenta también como que es un cierre temporal, buscando también un beneficio global de mayor largo plazo, ¿no? Entonces, digamos que lo que yo he entendido, traduciéndolo a la mentalidad de un economista, es que tenemos que envolver, digamos, todos los derechos fundamentales para discutir una discusión legal que tendría que envolver a muchísimos juristas, desde luego, para ver cuál es el papel que tiene cada uno de los derechos fundamentales dentro del conjunto de todos los derechos fundamentales. So, thank you very much for the presentation to all of you. I see that we are a bit late, but still I want to have some discussion and some comments from the audience. So if anyone would like to ask any question, or si alguien quiere hacer algún comentario o alguna pregunta, just feel free to comment or discuss with any of us. We can discuss later among ourselves, so I'm not worried about that. But if anyone of the audience would like to say something, this is the right moment. Please, Alex.
Thank you all so much for being here. It's so amazing to hear all different perspectives. I guess more of a roundtable question. What was the most surprising thing you might have heard from each other?
Can you be more specific?
Just that you all come from different countries for the most part, different perspectives, probably hearing some new perspectives for the first time. Was there anything that kind of caught your attention that someone else might have said you haven't thought about before, or was surprised by?
Anyone would like to answer? Mónica?
Maybe one thing that I agree from what we all said was that COVID-19 and the pandemic really changed the world and the way we see the world from the future. And I guess this is going to be an ongoing change for everyone, for the international organizations on health, for the IT, for the law, for the countries that we need to exercise a little bit more of creativity in our health budgets. And I think that, but the thing is how pandemic changed the world and how, as the professor said, how the world responded to pandemic. Because one thing that we have to be clear is that was the first time that the world, we all said that the health cost and everything, right? But when the pandemic came on, we all united, private sector and public sector, in order to have, for example, a vaccine that helped the world to be the way we are now, again, free. So, I don't know, I think that was it.
For me, I think it's very impressed that we've seen countries around the world that's been increasingly adopted the new technologies to improve the healthcare systems. Like what you just mentioned, the colleagues mentioned about the smart healthcare systems in your country, and also David mentioned that in some African countries they start to use the smartphones to do some digital health.
Exactly.
We've seen all these new developments on the one hand. On the other hand, we've seen the less regulation on this topic. This is like classic questions, like classic topics. Like Professor Wang just mentioned, we have so many different types of human rights. Right to health is just one. But when we're dealing with all these rights, when we have conflicts, what we should do, we're still asking for like the better regulations. We've talking about countries that copy the other countries' regulations and failed. We've seen these lessons actually in the past, but how we can respond better. This is what also I mentioned for my presentation, that we need to really think of it, not just involve small communities. We need to involve key stakeholders to join these discussions because it impacts everyone in society.
La innovación para gestionar requiere regulación.
Yeah, innovation requires regulations.
Well, I think one particular issue actually that I will impact my thinking is that in the pandemic, and we have a very rigid social control and it's moving, one thing we should not forget, which is that for these advantages, particularly patients, their access to health in some kind of block, this means in almost every country, whatever. Now, during the pandemic, while we're protecting the right to health, we should not forget only the public health issue, which is very much important at the moment, but also each individual's right to health, access to health, is also very much important. So we should consider, even for the same right to health, the public health law is private health law is, we should also make a balance between the same kind of right to health.
You want to say something, Dave?
Yeah, very briefly. Before we started, I was talking to Mónica, and she was saying that now more than ever we need the UN institutions. We have all these existential threats to humanity, not just in terms of climate, but also the security situation in many countries. And I think for me, one of my observations about the pandemic is it's not over. What the pandemic has done is created huge fiscal holes in countries' budgets. The fiscal space for health has shrunk in many countries significantly. So our challenge is to make sure that we address that. We started with a really great presentation from our colleague from the IMF about how we should be arguing that health is not just a human right, but it's also an economic imperative. So I think we really need to be hammering away at that. And just to say also that I think we also need to be aware that in times when we do have fiscal constraints and health rights under threat, that it's usually the most vulnerable in our communities that are threatened. I mean, the right to health is all about solidarity, and we are increasingly seeing less and less solidarity, particularly in countries where we have populist movements who are actually blaming some of these groups rather than protecting their rights. So I think we have many challenges ahead of us, but I'd just like to finish by saying that I think that the UN institutions are more important now than ever. I think that they undoubtedly need to be reformed, and there's a significant reform agenda going on. But I think we really do need to put our weight as lawyers, put our weight behind these institutions for the good of all. Thanks.
Yeah, and I'm gonna close with just three comments that I think that have been present here in the different words from by the different speakers. First, the global problems need global solutions. When we have a global problem, we cannot go to the particular country and see the regulation here or there. Second, there are different stakeholders that should participate in the decisions, not only one, but maybe also sometimes patients, and sometimes the policymakers, and sometimes public managers, and I mean, basically everyone should have a word in what we should be doing. And as an economist, I have to say, we shouldn't forget, Dave just mentioned, the word sustainability, because we not only need to have the access to health, or the right of access to health, but also this access should be sustainable in time. And for doing that, we really need to have the proper incentives to do that in the work. So thank you very much for this excellent panel. I'm very happy with the result. I am really sorry about